Welcome back to Module 2 of Running Mechanics, Assessment, and Application. I'm Dr. DeFabio, but hey, this is what we call Run Better, Run More. So thanks for tuning in. For those of you who aren't familiar with me, I'm a chiropractic doctor in Berkeley Heights, New Jersey. I'm board certified in chiropractic sports injury management, physical rehabilitation, and chiropractic orthopedics. And I've been in private practice for 35 years, and this is one of my NADA seminars. No cost, no CEUs, nothing but information, just to share some concepts about running mechanics and as it relates to improved performance. So let's take a quick recap of what we did in the first module, and after that, we're going to go into the application. So the first module we talked about running is a linear activity. Any movement patterns that aren't propelling us forward, that aren't accelerating us forward, is a waste of energy, a waste of resources, which is ultimately going to not only decrease performance, it's going to lead us to injury. We talked about the anatomical checkpoints, making sure everything is in alignment, both statically and dynamically, and that's what we're going to talk about today, is the dynamic assessment. After that, we looked at the importance of restoring proper mechanics to the joints, making sure joints that are stiff are freely movable, they're moving properly, making sure that joints that are loose get stabilized, balancing the length-tension relationships between the muscles in the front and the back, the left and the right, maintaining that symmetry. That's all about improving mechanics. Just like an engineer, just like your car, you got to improve the mechanics. When the front end and the alignment and the shocks are working great, there's less wear and tear on your wheels, you get better mileage. Same concept with your body. Then we're going to talk about, in the application today, the concepts behind a running mechanics boot camp or a running mechanics clinic. That involves nutrition, balance and agility, core stability we touched on a little bit, dynamic warm-up, dynamic cool-down, shoe selection. So those are the things we talk about there. We go over how to keep your muscles healthy, specifically, for runners, but it applies to all athletes. And then we'll tie it all together for you. So that's what we're going to do today. We talked about the review. Keep everything linear. Keep those eyes level, the shoulders level, the hips level, even arm swing. Arm height or hand height is equal on both sides. That will help avoid overstriding, understriding, and hands are relaxed. Nothing in your hands, right? I really beat that to death in Module 1. But it makes so much difference because you got to keep that upper body quiet. And you don't want tension there. Increased tension leads to increased energy utilization, which means decreased performance. You're burning up calories holding stuff in your hand. And you're tightening up and you're getting an imbalance in your mechanics. So I'll get off my horse. So that was the review. Let's go into today, the overhead squat assessment. This is the dynamic assessment of the any athlete, any person, but today we're talking about running. And there are certain patterns that we're going to see. But basically we had our static assessment, our postural assessment, and the dynamic assessment is the same anatomical checkpoints. Eyes, shoulders, right? Where are your elbows? Where are your hands? Where are your hips? Or where are your knees? Where are your feet? Right? It's all the same checkpoints. And we do it in 4 different positions, okay, the overhead squat assessment. So we call it OSA 1, 2, 3, 4 for the sake of the lecture here. And this is your basis of a corrective exercise prescription. When you see how people move and we're looking for normal mechanics, balanced mechanics. This isn't sports specific yet in the OSA. The sports specific is applying it to running. All right. Then we can set up a treatment plan. Where do you need adjustments? Where do you need mobilizations? Where do you need stabilizations? Where do you need stretching? Where do you need strengthening? And we're also going to talk about the corrective exercise paradigm of rehab. So common distortions are down here, but we'll talk more about that in a moment. I did mention on the first module my series of articles, so you may want to write this down. The one on the overhead squat assessment specifically is the 4th article, which was published in November 2019 in Dynamic Chiropractic. They're online, they're free. So I would read all 4. January talks about the talks about the back squat, the unloaded back squat as an assessment tool. Very good, just as a foundation for sport and as well as for life. The second issue talked about deficits in the upper domain from the waist up, deficits that are commonly seen and how to treat them. The August issue was deficits in the lower domain, waist down, and how to treat them. And November is squat variations, and specifically the overhead squat assessment, and the treatment algorithms also there as well. All right, so great articles, check them out. So the first position for the overhead squat assessment actually isn't this. The first position is standing with the arms elevated. This is the squat being performed. But what do you need to do? First, the feet are under the hips. It's not a narrow base gait. It's not shoulder width. Okay, for a traditional back squat, we want shoulder width, but this is an overhead squat assessment. We want to standardize all of your athletes the same way, and you want to make sure everybody does it the same way each time they do it. So they're going to be hip width apart because that's anatomical neutral. That's where we get up and down. That's where we stand. That's where we walk. That's where we live. If you can move in anatomical neutral efficiently, then we can translate it to sport. Yes, we're talking about running, but it translates to anything. Golf, tennis, swimming. It translates to anything. You got to be able to move first in neutral. Notice no shoes. Okay, stocking or bare feet. If your athletes wear orthotics and train in them, putting them in stocking feet is going to reduce their foundation. So you're going to see some weaknesses in the feet, in the lower leg. All right, we can expect that. But we want to see what they are, all right? And then if you're finding that's a real imbalance and it's throwing other things off, then you can let them stand on their orthotics to give them a little bit of support, but not a lot of control. Doing it with this running shoes on and the orthotics is going to give them a lot of control. And you're not going to see all the deficiencies and imbalances that are there. So the starting position is hands up over the head. The arms need to cover the ears at all times when they're up. Okay, so the arms need to cover the ears. If they can't cover the ears, you know you have a problem right there. There's some sort of deficit in the shoulder girdle region. The eyes stay level, the shoulders stay level, the hips stay level, and the squat goes to at least 45 degrees to 90 degrees. A traditional back squat is till 90 degrees. The overhead squat, we want to go at least 45. What do we look for? We look for these two lines here are very important. We're always concerned about your tibia torsal lines, the angle of the upper body through the arms, and the angle of the tibias. Those lines should be parallel or very close to parallel. Okay, that's normal. That means you have a good hip hinge, good hip drive. That means the shoulder area is not overly tight, that you can hold it up on you, and it means that you're not getting excessive anterior forward translation of the knees. And then from the side view, the same anatomical checkpoints as before. Everything's level, knees are over the foot, and tracking over the first to second toe. All right? So overhead squat assessment, first position, real straightforward. And for the runners out there, for the coaches out there, get out your phone. Have somebody take 4 pictures of you in these positions. Set it up remotely and do a video. And then you can see where your deficiencies are. What we really see is stuff like this. Here, the heels are up, very common, okay? The knees could go in, one could go in, they could go out. We talked about that in Module 1, valgus and varus. Hips drop, they also scoot off to one side. Very, very common findings, okay? The other common findings are the arms start to track forward. See, they're not covering the ear anymore. The arms are tracking forward. What does that tell us? That tells us there's tightness in the chest. Maybe there's some tightness in the lats, all right? But they're unable to maintain stability through the shoulder girdle when they engage their hips, all right? You also notice that she's not very deep, and she's not getting a good hip drive here, all right? If she were to elevate her heels, she would probably have a much better hip drive, but that's OSA 2, heels elevated. But this is what we commonly see. Poor hip drive, arms drop forward, and then something's going on with the knees and the hips. Real common, okay? So that translates to the second position, which is with the heels elevated about 3 inch. Just elevate them a little bit. You know, a great thing to do is just keep a 2x4 in your treatment room, and just pull the 2x4 out, put it on the ground, and they can just put their heels on the 2x4. So it's a great simple way to screen. Also, the thing that works well if you're in a rehab facility, a half foam roller, a foam roller cut in half is about 3 inches high. That also works really well. So whatever you have, but it needs to be between 2 and 3 inches, okay? And heels elevated, arms are still over the head, and we want to see the arms continue to cover the ears. That's perfect. We want to see that tibia torso lines. This is off a little bit, okay? So he's getting nice hip drive, but a little bit of increased anterior translation, so he needs to be sitting back a little bit more here. But generally what we see is you'll get a better depth when the heels are elevated. Why? Because most people wear shoes with an elevated heel. From the front view, eyes are level, shoulders are level, knees are tracking over the feet, okay? Same foot position, hip width apart. Check the feet. Do they turn out? Do they turn in? Does one collapse? It may change. Now, if this changes, whether it gets better or gets worse, that tells us that there's something going on in the lower leg, ankle, and foot. All right. If it improves it, there's a deficit in the lower leg, ankle, and foot, maybe a tightness in the gastroc soleus, the posterior chain, maybe a loss of dorsiflexion of the ankle, maybe a loss of dorsiflexion of the great toe. Who knows what it is? That's where the clinical part comes in. This tells us that there's something going on with the ankle and foot. Maybe it's an old ankle injury that hasn't healed. Who knows? That's where the clinical part comes in. But it tells you something's going on. If it gets better, that means we need to fix that to improve mechanics. If it gets worse, that means it's a compensatory reaction, and we have to figure out what it's compensating for. Very unlike in the last scenario. OSA 3, the third screening position, is hands on your hips. Feet are still hip width apart. This time hands on the hips. Very nice. Tibia torso angle is great. Lumbar spine's not arching excessively. It's not rolling or no butt wink, we call it. Notice how the torso's not falling down, right? So that's really excellent. From the front view, the knees are still tracking over the feet. If I was to be real particular, I'd say maybe the feet are rolling in a little bit, but that's not bad at all, okay? But this is a pretty good hands-on hips. So that's the third position. What we usually see with hands-on hips is one or both of the feet will turn out, or sometimes they turn in. This is super common, is they start to bend forward from the waist. See, we've lost that tibia torso line. Why is that a problem? Or it's a problem because it's an imbalance. Why is it common is the better question. It's common because we're so hip flexor dominant. And what do runners do? They're using their hip flexors all the time, right? So we put our hands on our hips. We've taken our lats out of the equation, our upper back out of the equation has stabilized our muscles. Now it's just the power of the glutes and hammies and lumbar spine versus the power and strength of the hip flexors. There's a relative imbalance between the posterior chain and the anterior chain when you see this, all right? Very common. Now, could it be that there's a lack of mobility somewhere? Maybe they can't squat any deeper than that because there's arthritis in the hips. Maybe the knee is swollen and inflamed. Maybe the ankles can't dorsiflex. Maybe that's why they can't get down. So the easiest way to screen whether it's a mobility issue or a stability issue is to grab some TRX straps and squat again. If you can squat deeper and maintain that tibia torso angle, guess what? It's a stability issue. Your posterior chain isn't strong enough, or you don't have the psychomotor skill to control it, okay? If you stop at the same spot or just about the same spot, holding on to TRX, guess what? It's a mobility issue, okay? That means something's not moving right and it better get restored. Otherwise, you're not going to get anywhere. They go hand in hand, but when you have a mobility issue and a stability issue, the stability issue is secondary generally to the mobility issue. If you don't restore the motion first, strengthening it and stabilizing it isn't going to make it better. You can stabilize around it, but you got to restore that motion. So as a rule of thumb, stability is secondary to mobility, or to reverse it, mobility trumps stability in the treatment corrective exercise paradigm. And the last position is a single leg quarter squat. It's also called your dynamic Trendelenburg test. Same anatomical checkpoints: eyes, shoulders, hips, knees, foot. And this is a quarter squat. This is not a pistol squat. It's just a little tiny quarter squat. I usually have them do 3 or 4, okay? Give them a chance to catch their balance. Once they catch their balance, you do a couple. And this is generally not what you see. This is what you see. The hip will drop, the knee goes in, may or may not be related to pronation and external rotation of the foot, all right? The arch collapsing. When people stand on one leg, when your runners stand on one leg, if there's a lot of balance issues, reset. And when they reset, be attentive to where they break down first. Do they wobble at the foot first? Do they wear orthotics? Do they wear and run in a stability trainer? Do they start to wobble in through the hips and the knee first, and then the foot collapses? Because if it starts from the bottom up, well, that's another OSA reality that you see. But if it starts from the bottom up, you can think it's a foot problem, a lower extremity calf problem, anterior tibialis or posterior tibialis. Both of those muscles lift the arch. Maybe it's an intrinsic foot stabilizer muscle issue, weakness. But if you see the knees start to go into valgus, and the hips start to wiggle, and then they lose their balance, it's core, it's glutes, it's glute med, okay? Glute max, core, hit that hard. And then slowly teach them how to do Bulgarian split squats and split squats to retrain the movement pattern where they can keep the knee over the foot and engage the VMO, but it's hips. So be attentive to those balance issues. Oh, I got bad balance. I can't stand on one foot. Yeah, but where's it coming from? Yes, it could be visual. It could be vestibular. There's lots of reasons you have balance issues. But when it comes to the purposes of the overhead squat assessment, again, you need to look at the whole kinetic chain. And as a chiropractic doc, that's what I'm all about. I want to see that whole kinetic chain, and that ties me into where the weak areas are that need to be strengthened, where the tight areas are that need to be lengthened, where do we need to do mobilizations, where do we need to do stabilizations, and then we integrate it into compound movement patterns and life and sport. Common distortions, we talked a lot about them. We didn't hit anterior knee translation, where the knee goes way too far forward and that tibia torso line's off. That means he's got no hip hinge. The knees we've talked about. Low back rounds like this, a butt wink. You can even see the neck. Don't forget about the whole kinetic chain. Goes all the way up. Make sure you look at the neck. That should also stay in neutral, and the low back could arch. So let's talk about some of the more common distortions you're going to see. And with our runners, you're going to have generally tightness in the calves. Why? Because most runners wear a shoe that's got anywhere from an 8 to 12 millimeter ramp, which means their gastrocs and soleus are going to be a little short. Okay? You're going to see dominant hip flexors because they train so much working hip flexion versus extension, pulling through. We just generally hit those glutes and the hammies enough. That's the other common distortion you're going to see, okay? And the imbalance in the single leg squat and dropping pronation of the arch. So those are the 4 most common imbalances you're going to see. What's the treatment algorithm? Well, let's go through the OSA. First, you do it neutral. Arms up, make sure they cover the ears, squat down 45 to 90 degrees, check their anatomical checkpoints, all right? Then we elevate the heels. We talked about it. If it improves, that tells us that the lower leg is involved from the knee down. Something's involved. If it gets worse, that means the lower leg is throwing off a compensatory reaction somewhere else. Then we put the hands on the hips. That indicates that there's upper domain involvement. So arms here, then arms down here. If there's a change, something going on with that upper body that's impacting the squat mechanics. What's the only muscle that attaches from the lumbar spine to the shoulder? It's your lats. That's the only muscle. So if you're taking your lats out of the picture and your overhead squat changes, it's a major stabilizer for your lumbopelvic hip junction. Other areas could be your mid and lower traps. But again, you got to be thoughtful in how you approach this. Then you go into a single leg. The single leg, you're really going to see somebody have a better movement pattern. That's very unusual. Usually we see the foot will pronate, knee will go into valgus, and the hips will drop. If the hip drops, we know it's a glute med weakness on the weight-bearing side. If the hip elevates, and this is your weight-bearing side, it's still a glute med weakness because now the QL is just overacting because this isn't working enough. So hip drop, hip hike, still a glute med weakness. And I got news for you runners. You got to hit your hammies and your glutes more as a rule of thumb, especially those glute meds for lateral stability. And we talk about that a little bit when we hit balance and agility. If they pass all of those, they pass the OSA 1, 2, 3, 4, and you still want to challenge them, then you can add hops. You can add jump downs off of a 12-inch box. You can add tuck jumps. So you can add more dynamic, more plyometric type of activities. The other thing I didn't mention, the OSA algorithm, your overhead squat, and any functional assessment algorithm is for the pain-free athlete. This is not to find a pain generator. That's a whole nother animal. Assessment for pain and dysfunction is a whole nother animal. This is to find the areas that are dysfunctional that aren't painful. All right? If you do any one of the OSA parts, neutral, arms on your waist, heels elevated, single leg, and you get pain, you stop and you evaluate why they're having pain. Then, when they're pain-free in that position, you can evaluate their mechanical imbalances. Very different point for the clinicians out there and for the runners. Let's talk a little bit about treatment. You know, chiropractic adjustments are the mainstay when a joint isn't moving properly. We do it all day long for the trainers and the therapists out there. Coordinate with your local chiropractic docs. Develop a team for the chiropractic docs out there. Develop a team with the therapists and the trainers out there. We all have our respective jobs, and together, the athletes are going to get what you want. And again, I said on the first module, for the athletes, put together a team of acupuncturists, massage therapists, physical therapists, chiropractic doctors, sports med guy if you need something more than that. Have your team. Let's keep you in the game. So adjustments, SMR means self-myofascial release, foam roller or a stick. Here's the stick. This one's got ridges in it. The foam rollers have bumps on them. They don't have bumps on them. It's personal preference. The bottom line is have them both and use them both. Now, when do you use them? Well, let's think about it. If a muscle's tight and it's not compliant, not as elastic as it should be, and a lot of times it's tight and weak, all right? But let's just say it's tight. If we go ahead and train on it, we're training on an area that's tight. But if we were to foam roll it, if we were to stick it to kind of loosen it up a little bit, to get more compliance and elasticity in the soft tissues, then train on it, we're going to reinforce a correction. So we're going to foam roll or stick definitely before exercise. Now, we all know stretching's not a warm-up, right? Research has shown stretching does not improve performance. However, if you really want to stretch, you foam roll and stick, you run a little bit, break a light sweat, then you can stop and stretch. Stretching works on warm muscles. About the foam roller. When you're using the foam roller, you find those areas where they're tight and you sit on them. That's how it really releases the knot, is you sit on it, okay? And that's like self-ischemic compression, self-pressure point, all right? Self-shiatsu, whatever you want to call it. But that's how it works. By just rolling up and down on the foam roller, that's okay, but that's the same as a stick, like we have here. Now, sticks are great because they're portable. They're a little more superficial. You don't have to get on the ground. So anybody that's got a shoulder or a wrist problem isn't getting on the ground. And if you're going to a race or to the track, not too many people like to roll outside because the foam roller gets dirty and then it's a mess. But the stick is portable. You don't have to get on the ground. And it works really, really well. So definitely do it before activity. And after activity is also okay. You can do it both, but you really have to do it before. I prefer, personally, stick before, foam roller after. But that's just me. You can go to my YouTube channel, and I have 2 videos on there on foam roller and advanced foam roller technique. Research has shown foam rolling with motion is even more effective than isolated, so that explains it on my video. Once you loosen up the muscle, we talked about this a minute ago, then we strengthen it. So again, let's talk about the patient, you're a runner, you have some pronation, right, on your single leg squat and on your overhead squat, and we put you up with heels elevated, and you don't pronate so much, but all the other positions you pronate and the foot turns out. So that tells us we need to strengthen both the anterior and posterior tibialis, because they both work on holding the arch up. So you have to find those muscles. You have to do isolated strengthening of just those muscles. Once you find those muscles and we build up their strength a little bit, then we can talk about jumping, hopping, running. All right? Does that mean you have to stop the training? No, but you have to do some isolated strengthening to find those, to target those. And sometimes I'll do isolated strengthening for maybe 1 or 2 weeks just to isolate a muscle. But you got to keep your cardio up with runners. So that's where your cross training comes in. Once we get the strength going, then it's the integrated strengthening. So here's when we're coming on rehab. This is the rehab paradigm, okay? If it's you're coming off an injury, this is where we start to strengthen it individually and then globally. So again, isolated anterior and posterior tibials exercises. Then we can go to some exercises, barefoot balance exercises, quarter squats on a BOSU. And then from there, we can go to jumping mechanics and hopping mechanics, and then box jumps, and then running and jump rope and sprinting, etc. After integrated strengthening and you're doing multiplanar movement patterns, then we talk about balance and agility, okay? If you don't have the stable issues first, then the area to work on the proprioceptive component, it's not going to get maximum benefit. Agility for the runner is really important. You're running in a crowd and someone's throwing elbows. You don't want to, number one, fall. Number two, if it's a race and you're coming around a turn, you don't want to lose any time or speed. Number three, if you're running off-road and you're on rocks and stones and roots, you don't want to trip. And how about if you're on the street and the street's uneven and the sidewalk goes up, or there's a little bit of a divot in the road? You need to be able to stabilize yourself quickly for those imbalances, and that's where agility training comes in. The simplest way to train agility training is go out to a empty parking lot and find one of the lines there and just do some back and forth with your feet, some karaoke drills, some grapevines, jump over, jump back, jump over, jump back, just to get some agility going. Finally, in the exercise algorithm, this is how to progress your exercises for the therapists and the trainers and the doctors out there. You add power and speed. Speed kills. How many times have we heard it? I was doing great till I did a speed workout. I just had one more set to go and the weather started to change, so I pushed that last lap a little hard. I pushed that last set a little hard. I had to get back in the car quickly, had to get back home quickly, and that's when people get hurt. Speed kills, so respect it and respect the volume. Same thing with power. Too much too soon. That's what's going to get you into trouble. So that's the algorithm. Once you find the areas of deficits, how to reintroduce the rehab. Same thing here, just a different picture of it. All right. Once you have better mechanics, then coaches, this is where you jump in. This is where you coordinate with your coach. Then you can do the technique changes, because the athlete will be able to align themselves this way. They will be able to push through and follow through this way. They will be able to have better lean and arm swing. Now the coach can talk to them about heel strike, toe off, follow through, knee height, stride length, the lean, your arm swing. First you fix the mechanics, then you do technique, which means you run better, you run more, and your performance improves. You can use the overhead squat assessment as a simple race day screening tool to give a service to your runners. I like to do it not only that way, but as a boot camp or a workshop. And how I structure the workshop is through 9 different parts, okay? And I do it as a 2-hour class generally. Sometimes I'll do a running mechanics club, and I'll do it over 9 weeks. We do 1 component a week with a group run. I only talk for a few minutes. Everyone gets an overhead squat assessment and a corrective exercise prescription because, again, we want everybody to run better so they can run more. We go over dynamic warm-up. Dynamic warm-up is a warm-up, okay? It's not stretching. Stretching's a cool down or when your muscles are warm. Dynamic warm-up, research has shown, works really well. A lot of athletes do it. Batters do it. I don't know the warm-up circle, right? They take practice swings. Golfers, practice swings. Runners, you got to warm up, and you can do a dynamic warm-up. Core exercises. Got to hit the core. All right, we talked about it in Module 1. Planks are excellent. You got to engage the diaphragm with abdominal breathing. You need to work on the glute medius. They're not core muscles, but they're stabilizers, okay? Got to hit the glute medius. I love side-lying glute medius and clamshell progressions. Make sure you do your planks. Make sure you engage what's called your transverse abdominis muscles as well as the internal oblique. And remember, your rectus abdominis, your six-pack, is not a core stabilizer. It's a power muscle. So it's not going to give you stability. It's going to give you power. You got to hit those stabilizers, all right? Proper use of a foam roller and stick. We talk about that. We teach them that. And these are things we teach to the runners. So this is a boot camp. It's a clinic. It's a program for the community, for your runners, okay? We take a day and we talk about balance and agility, and we talk about the importance of that, and we teach them simple drills they can do on their own. Nutrition. What do we talk about? Simple nutrition. Basically, you want to look at what you're eating on an everyday basis. That includes hydration. Hydration is a daily thing. It's not a workout day thing. It's not a race day thing. Water is really important. And if you're properly hydrated, you're going out for a 30-minute workout and it's not super hot out, or you're not in a new environment where you have to acclimatize to the environment. If it's not super hot, 30-minute workout, you don't need to bring water with you if you're properly hydrated. 30 to 45 minutes, you need to have some sort of hydration. After 45 minutes, you need to have hydration, and you also need to have a nutrient source, a fuel source. Protein drink, carbohydrate drink, whatever works best for you. So you have to try these in training. You don't try them on race day. You try them in training. I mean, going back in the days when Gatorade, back in the early 90s, when Gatorade took over the Ironman World Championships in Kona, they put Gatorade on the course. And they gave it full strength and had a lot of problems, a lot of GI distress. A lot of people crashed and bonked because a lot of fructose, which irritates the stomach, and people weren't used to it, okay? So the following year, they changed the formulation a little bit, and they also diluted it a little bit. So changing your nutrition is not a race day thing. And complex sugars will help you sustain longer than simple sugars, but simple sugars do have a place in shorter races as well. Stretching and cool down. You got to stretch. Muscles need to be compliant. They have to be able to lengthen, and they have to be strengthened. That's part of your cool down, and we teach people how to cool down properly. I mean, I just had a runner came in this year, and weather changed, ran, stopped her run early, jumped right in the car, drove an hour, got out of the car, and her hips turned into cement. Not a proper cool down, and it's been a bear to fix it. Shoe selection. We talk a little bit of time talking about getting the right shoe. It is based on your foot. The shape of your foot will determine the shape of the last of the shoe. If your foot needs a curved last, get a curved last. If your foot doesn't, get a straight last. People with high rigid arches, generally have a more stable foot and need less control. People whose arches drop more may need more control, may not, okay? I've seen some very high-level elite runners with flat as board feet, okay? So just because the feet are flat doesn't mean they need more control. The widest part of your foot has to match up to the widest part of your running shoe. That's an important tip. And you get one that fits comfortably, All right, and lightweight is always a good choice. And depending on how you run, and if you wear heels all day, running in a shoe that's got a neutral ramp may not be a good choice. All right. If you wear flats, if you wear negative sole shoes all day, yeah, no problem transitioning to a minimalist shoe with a zero ramp. So it's got to match, what you do in life too. And then at the end, we do a short run to put it all together, okay? So they get the concept of running as a linear movement, and as you're running with them, you can say, oh, can you feel how your knees are doing this, or your hips are doing that, or drop your shoulders down, lengthen your head up, relax your arms, all those little cues. So it's a lot of fun. So those are the Running Mechanics Boot Camp. All right, so a lot of information. I hope I didn't overwhelm you. I appreciate you tuning in to my NADA seminar. Additional information, NASM, about the overhead squat assessment. Read my articles on dynamic chiropractic. That's me. There's my contact information. Check me out on YouTube. Well, you probably are right now, but please like, subscribe, and let me know what you want to hear, because it's all about you, because this is no cost, no CEUs, nothing but information. I'm Dr. Donald DeFabio. Thanks for tuning in, and we'll see you on the next show. Aloha.